Another thing many of you may know or may not know that Rabindranath Tagore spent quite a bit of time here, and this place Shillong has been immortalized in his two writings. One is Letter from Shillong, and one is his most famous novel, Shesher Kavita, or the last poem. So if you haven't read that novel, you should read that. One of the line where the main protagonist Amit Ray is telling Lavanno, for a moment, hold your tongue and let me love. So it's a place full of love. Anyway, for a time we should concentrating on the topic, and I think we are already late. So I've been asked to talk about molecular profile-based treatment of non-small cell lung cancer. Anything like a prologue, I must tell a bit about the epidemiology of lung cancer in India. It's a bad disease, fourth most common as a single disease entity. Second most commonest cause of death among male, roughly 67,000 new cases and 63,000 death every year, which makes the case fatality ratio close to 85%, being one of the highest after pancreatic cancer. This is the current non-small cell lung cancer therapeutic profile. So we have the artillery guns, like the chemotherapy, which histology subtype regarding chemotherapy like small cell, non-small cell, and we bombard them. Then came the earlier incest rifles, the targeted therapies, and now we have got these very sort of sniper rifles like checkpoint inhibitors, or should I say the stealth bombers. So the lung cancer treatment in 2019 does not mean chemotherapy, surgery and radiotherapy alone. So it's a era of personalized therapy. One size doesn't fit all. Evolution of targeted therapy has made treatment armamentarium wide, patient specific and optimized. Next slide please. So if you look at this, first, initially we only knew non-small cell lung cancer as a single disease. Then came that we know there is a squamous cell cancer, there is an adenocarcinoma, and there are about 10% others, include adenosquamous and various. And now we know that almost 50% of non-small cell lung cancer has some sorts of mutations of biomarker. Of course, the biggest of them is epidermal growth factor receptor, EGFR, but we also have ALK, we also have the ROS, the MATE, HER2, BRAF, PI3 kinase, AKT, MAPK, NRAS, and so on and so forth. And also in squamous cell, we know there's some percentage of squamous cell has EGFR mutation and PI3 kinase mutation. So before we go for does it work? No, is the pointer works? Anyway, that doesn't matter. So before we go for the treatment, we must know how to get the molecular testing done. So this is, sorry, next slide please. Can I go to the next slide please? So this is the diagnostic algorithm for advanced non-small cell lung cancer. So initially the physician identifies the patient, then there is a multidisciplinary tumor board, which includes the oncologist, the surgeon, the radiation oncologist, pulmonologist. They decide about the disease and treatment, and then the medical thoracic and radiation oncologist decides about the imaging, especially the PET CT or CT, including a brain MRI. Routinely are doing brain MRI even in non-small cell lung cancer, and we are getting almost 20% of them having brain mets, asymptomatic brain mets. Then we need a tissue biopsy, for which we sometimes need an interventional radiologist or surgeon. Then the pathologist for the initial histopathology, and then the minimal recommended biomarker testing, that is EGFR and BRAF mutation, ALK, ROS1 and PDL1. And ultimately the medical oncologist will determine the therapy based on histology and molecular profiling. It takes sometime between 2 weeks to 3 weeks to get everything done, from the early presentation to the biopsy and the molecular marking. So what is the optimal care of patient with advanced non-small cell lung cancer hinges on tumor biopsy and pathologic evaluation. So adequate biopsy specimen is essential, as patients with specific molecular alteration have significant improvement in anti-cancer response, progressive failure rate. And 85 to 90% of the mutation are either deletion in the exon 19 or a single point mutation in exon 21 called L858R. The specific EGFR mutation identified is important because they are sensitive mutations, primary resistance mutation, especially often in exon 20, and de novo and acquired resistant mutation like T790M. So, if you look at these, all this data will be, sorry, can I have the next slide? I'm so sorry, I'm having this problem of, can I have the next slide? Yeah. So, these are the different study on which the use of anti-EGFR targeted therapy, the TKIs has been done. I'll be discussing few of them. Can I have the next slide, please? Can I have the next slide, please? Next slide. Yeah. So, if you look at the Gefitinib, that IPASS trial, which was a sort of a paradigm shift, this is a trial which showed that when Gefitinib was put against chemotherapy, though it did not show, initially they used it in all patients, irrespective of the EGFR mutation. And in the final primary endpoint, there was no difference between the Gefitinib and chemo. But when they did the exploratory analysis, which was in EGFR mutating patient, they found that there is almost 40% improvement in progression-free survival from 6.3 months for chemotherapy versus 9.5 months of progression-free survival. Can I have the next slide, please? Similarly, another phase 3 trial, open-label trial for Arlotinib called UTAC. Their primary endpoint was progression-free survival benefit, and it met its primary endpoint. The PFS for Arlotinib was 9.7 months versus 5.2 months for chemotherapy. However, the secondary endpoint, the overall survival, there was no OS advantage was seen. So there was improvement in overall response rate, improvement in PFS, but OS remains more or less similar. Then came this drug called Afatinib, and there was 3 studies for Afatinib all called Lux-Lung, very catchy name. By doing the Lux, I always remember that Lux soap. Anyway, so that Lux-Lung has a 3 study, Lux-Lung 3, Lux-Lung 6, and Lux-Lung 7. So again, the primary endpoint was PFS, which they showed that there was a definite improvement in PFS, 11.14 months, 14 months versus 6.9 months. And the overall response rate was almost double, more than double in fact, 23% versus 56%. However, they did not find any overall survival advantage. Similarly, when they did it, the Lux-Lung 6, where the Afatinib compared with the cisplatin and gemcitabine. Previously it was, I think, with pemetrexed, cisplatin and pemetrexed. Then they did it with cisplatin and gemcitabine. Again, they found that the primary endpoint was met, the PFS was more than doubled, but overall survival advantage was not seen. Then what they did, they clubbed these 2 trials together and did a subgroup analysis of special interest having an EGFR mutation of deletion 19. And voila, they found there is an OS advantage among deletion 19 patient when compared to chemotherapy. But ladies and gentlemen, please be advised, this was not their original data. So they say if you can flog a person or a data enough, you can get anything out of that. So after flogging this data, we found that there is some OS advantage among the deletion 19. Sorry. And this is the phase 2B open labeled Lux-Lung 7, where Afatinib was compared with a previous generation of TKI called Gefitinib, and they found that the co-primary endpoint, the PFS, was 11 months for Afatinib and 10.9 months for Gefitinib, but it was statistically significant. It was statistically significant. And another co-primary endpoint, time to progression, was again better for Afatinib versus Gefitinib. However, the overall survival advantage, which is another co-primary endpoint, was not seen, though it was numerically better with Afatinib, 27.9 months versus 24.5 months. So OS advantage was not seen when compared with the other TKI, but PFS advantage was there. Then, with the last year's published data of the FLORA trial, where they use this drug, new drug, third generation TKI inhibitor osimertinib. They set a new standard of care in first line of treatment in EGFR mutated NSCLC, and this shows almost a doubling of the median PFS versus the other TKI, standard of care TKI. The osimertinib median PFS was 18.9 months, but the SOC TKI, that is the standard of care, so the gefitinib or erlotinib, it was 10.2 months. So based on, sorry, can I, yes, can you have the next slide please? And so, can I have the next slide please? Sorry, yeah. And can I have the next slide please? Yes. So, based on this data, the current treatment paradigm is, if you have a EGFR mutation positive, you have at least 5 drugs or 4 drugs: osimertinib, afatinib, dacomartinib, erlotinib, and gefitinib, of which dacomartinib is not available in India, so I will not be talking about. Among all these drugs, they are all approved for EGFR exon 19 deletion or exon 21 point mutation, and the preferred drug is osimertinib, but for all practical purposes, it is 5 times or 10 times more expensive than the standard of care. This is battery is running low. So we generally use one of them if there is a progression, and we do a repeat biopsy and find if there is a T790 mutation. If there is a T790 mutation and you have not used osimertinib previously, so you can use osimertinib based on another trial called AURA trial, which I'll be discussing. Or if you have already you have used osimertinib and there is a progression and there is no T790 mutation, then you can follow the treatment option of adenocarcinoma, squamous cell carcinoma with whatever the actionable biomarker is there, or you can use chemotherapy. So this is the FLORA trial. This is a phase 3 trial where they use osimertinib 80 mg daily versus erlotinib. The primary endpoint was PFS. This is the data I have already told. They also had a point of CNS progression, and they found that using osimertinib, half that CNS progression. Sorry, can I? So if you have a standard EGFR TKI like gefitinib or erlotinib, and you can see the CNS progression almost in 43% patient, where if we are using osimertinib, it is about 19% of the patient. Can I have the next slide, please? And the interim analysis overall survival that for osimertinib till the time of this was 2017 data, was not reached, but there is a hazard ratio of 0.63, which means almost 47% improvement in median overall survival. Can I have the next slide, please? So adverse reactions for osimertinib according to FLORA was quite standard, and it is in fact comparable to all standard of care. Can I have next slide, please? Yes. So once the disease progress on EGFR TKI, what you do? So if the progression of disease has a global progression, slowing the growth globally and growth in several areas but not all, and you look for a molecular characteristics, whether it has changed from non-small cell lung cancer to small cell lung cancer, whether you have an EGFR T790 mutation, which is found in exon 20, you have a MET amplification, if you have PI3 kinase mutation, or even other pathways. So these are the, if you look at the pie chart there, so these are the different percentage of mutations. So of which about 40% is T790 mutation. Now this trial, AURA3, which put osimertinib versus platinum and pemetrexed in EGFR T790 mutation positive advanced breast cancer, and the primary endpoint was PFS, and they found that the median PFS for a progressive disease was almost 10 months by using osimertinib, where platinum and pemetrexed had only 4.4 months. Basis of this, osimertinib was approved by FDA for a metastatic EGFR T790 positive non-small cell lung cancer. Now, many of the patient has a difficulty to get a biopsy on tissue biopsy, so liquid biopsy became popular. But liquid biopsy has about 30% false positive rate, and false negative rate. So negative results will require a repeat tissue biopsy. This is most important. If you are welcome to do liquid biopsy to find a, but if that liquid biopsy comes negative, it is advisable that you really try to get a tissue biopsy. Now, treatment based on ALK rearrangement, it found is approximately 5% of the non-small cell lung cancer, occurs most frequently in younger patient. Predominantly a fusion of ALK gene with a partner oncogene, particularly AML4, occurs in a similar subgroup at patient with EGFR mutation, but ALK and EGFR are mutually exclusive. So if you have a EGFR mutation, you are not likely to have an ALK mutation. Can I have a next slide, please? Yes. So for the first line treatment with ALK inhibitors in ALK rearranged non-small cell lung cancer, we have basically 4 drugs available. Out of them, brigatinib is not available in India. So we have crizotinib, we have ceritinib, and we have alectinib. All 3 of these has phase 3 data. For crizotinib, it was profile study. For ceritinib, it was ASCENT. And for alectinib, there was an ALEC study and an Asian ALEC study called JALEC study. Out of this, crizotinib and ceritinib has been used against chemotherapy. It is only alectinib which has been used against another ALK TKI, that is crizotinib. So this is the ALEX data. Why I chose instead of the rest of the 2, that this is the only drug which has been actually pitted against, not a chemotherapy drug, but another similar drugs. And this trial, that is ALEX trial, which used alectinib versus crizotinib in untreated ALK positive non-small cell lung cancer. They used 600 milligram twice daily alectinib versus standard dose of crizotinib. And the primary endpoint was investor assessed PFS, and secondary endpoint was IRC assessed PFS. And alectinib, the curve started widening quite early, and they found that alectinib is superior to crizotinib. It has the median PFS is roughly 34.8 months, whereas the crizotinib is 1/3 of that, 10.9 months. The hazard ratio is 0.43, that is the improvement in survival by using alectinib is almost 60%. Not only that, another important point was time to CNS progression. It was found with crizotinib, the 12 months of cumulative CNS progression was 41%, whereas alectinib it is only 10%. So it is huge. Again, the side effect profile was found to be standard and not compared to crizotinib. There is another drug, brigatinib, which was again used in a trial called ALTA against crizotinib, and it also showed a superior PFS in comparison to crizotinib. Now, when this disease, they progress after previous ALK inhibitor, what you do? So standard, when one of the first drug which came is crizotinib. So once patient progressed after crizotinib, you use ceritinib. That was the standard. But once alectinib came, the things become a little dicey. So if you are using alectinib first line, if they progress, what you do? So normally if you use crizotinib, if progress, you can use ceritinib and then so then another drug come. So then you actually, sorry, can I have the next slide please? Next slide please. Previous slide. Yes. So this drug lorlatinib, has shown some better response once they progressed beyond alectinib. Can I have the next slide, please? So I can just stop this. Power has gone. Then there is another mutation called ROS1 mutation. Can I have the next slide, please? And this is very small a. There is a 1 to 2% of mutations of ROS1, but we always do that because if they are positive, you can use crizotinib. And if you have a BRAF mutations, we don't routinely doing it nowadays, but they're saying you can do it. So you have this drug, dabrafenib with tremetinib, but it is not available in India. You can import them, very expensive. Normally, I am not using it routinely or practice. Manish, are you doing it? This BRAF V600E mutations. If you are doing NGS, yes, absolutely. So as of now, if you are doing NGS, it comes as a package. If you are doing single gene, we don't do it. Can I have the next slide, please? So these are the emerging molecular testing, the MET exon, the rate rearrangement, the NTRK. There is a drug called larotriptanib, which is already being approved by FDA, available. We are planning to import for one of the ministers from Northeast, but unfortunately expired. And of course, there are 2 to 4% of HER2 mutations for which you can use the adotrastuzumab. Can I have the next slide? I'll be very quickly touching upon the PD-L1 expression and tumor burden. Can I have the next slide? So, KEYNOTE-024 is the first drug which shows pembrolizumab versus chemotherapy in a first-line therapy for advanced non-small cell lung cancer with a PD-L1 value of more than 50%. Can I have the next slide, please? And they have shown a superior objective response, CR as well as PR. Can I have the next slide, please? And a much better PFS. The only issue is that with pembrolizumab or for that any other drug of this group, that is checkpoint inhibitors, that unlike chemotherapy, their response are not linear. That if you use the RECIST criteria, sometimes have a faux pas. Because they may not, initially they may not respond. If there is something called pseudoprogression, there may be disease stabilization, and so on and so forth. So trying to use the conventional measurement sometimes make this data looks more, I would say, less positive. Can I have the next slide, please? So anyway, this KEYNOTE-024 shows that if you have a PD-L1 more than 50%, they definitely work. The pembrolizumab is way superior to chemotherapy. Can I have the next slide, please? Then came the KEYNOTE-042, where they tried to using that pembrolizumab versus chemotherapy in advanced NSCLC with PD-L1 anything above 1%. Can I have the next slide, please? And they show it also benefits. So even if you have a 1% of PD-L1, it works. But of course, it doesn't work as good as if it's a PD-L1, it's more than 50%. I'll just finish it. So PD-L1 is an imperfect biomarker, but it is the only thing we have. Can I have the next slide, please? I'll be just going through it. So they have tried these various of using 20%, 1% and 50%. They have shown that it works in all subtypes. Can I have next slide, please? So even if you see the 0 to 1 to 49% population exploratory analysis, it still shows there is an improvement. But of course, if the PD-L1 is higher, its response is better. Can I have next slide, please? So another group of drug, nivolumab and ipilimumab versus chemotherapy. Can I have next slide, please? Can you give the next slide? Has shown similar improvement. Can I have the next slide, please? So they have shown that most probably tumor mutation burden is a better marker than PD-L1. But presently getting a tumor mutation burden is very expensive and is not routinely done in labs, many of the labs. So we are not routinely doing tumor mutation burdens. When the cost really comes down, I think this will be a better biomarker in conjugation with PD-L1. Can I have a next slide, please? Okay. So if you look at this subgroup analysis, that if you have a tumor mutation burdens of more than 10 mutations per megabase, most probably it is going to be showing a much better response. Can I have a next slide, please? So this is for 2019 is the overall algorithm. If you have a molecular marker, if you have a EGFR mutation positive, you have a plethora of EGFR inhibitors. If you have the money, you can use osimertinib, but otherwise other anti-EGFR TKI you also do. If you have ALK positive, you have alectinib, which is preferable, but you can use crizotinib or ceritinib also. If you have a ROS1, you can use crizotinib. For BRAF mutation, you can use the combination if you have the money to import them. And of course, if you have a PDL1 mutation, you can use the checkpoint inhibitors. Can I have the next slide, please? So in conclusion, the molecular testing is essential in the management of advanced non-small cell lung cancer. Approved agent for EGFR, ALK, ROS1 and BRAF driver mutations are preferred as initial therapy. PDL1 expression has become a standard of care to identify patient candidate for pembrolizumab monotherapy, and combination chemotherapy plus immunotherapy is a new successful first-line treatment strategy. We are using this Lina Gandhi's paper of using pemetrexed with carboplatin and pembrolizumab, and we have used 3 or 4 patients, and in fact we have gone CR, radiological CR in 2 of them. So I think that is one area we are actively looking for, combination of immunotherapy along with conventional therapy. So that concludes. Can I have the next slide, please? So this is a question. What is this flower? Can I have a show of hand? How many of you knows about this flower? I will give a hint. This photo was taken today morning. Now tell me. This is a flower called rhododendron flower. Rhododendron flower. So again, going back to Rabindranath, in that book Shesher Kobita, or the last poem, there's a line when that protagonist is writing a poem and he's writing in Bengali, হঠাৎ কখন সন্ধ্যা বেলায় নামহারা ফুল গন্ধ বিলায়, প্রভাত বেলায় হেলা ভরে করে অরুণ মেঘেরে তুচ্ছ, উদ্ধত যত শাখার শিখরে rhododendron গুচ্ছ. I'll translate in my tuta-futa English that in the evening suddenly I get a smell of some unknown flower, and in the morning, in the early morning, the sunlit, even the sunlit clouds are bowing their head to those great rhododendron flower we are flaunting so highly on the mountainside. So this is, I took it from the Cherrapunji today morning. Thank you, ladies and gentlemen. Yes.
In stage 3 lung cancer,
yes.
unresectable lung cancer,
yes, sir.
one of had been approved in partial response for stable disease. Whereas in stage 4 lung cancer, primarily and liver has been used. What is the difference?
Can you just get your...
Stage 3,
yes, sir.
non-resectable lung cancer, where the people with CTRT,
yes, sir.
partial response for stable disease, development has been approved.
Yes.
Whereas stage 4 lung cancer, development not so that as a result.
Yes, so that's the crux of how the trials are being conducted. So in the era of evidence-based medicine, your guidelines actually decided what evidence you have. So durvalumab has been particularly put on that trial where post CTRT, if there is a stable disease or a partial response or a complete response as a maintenance, and it has shown result. But of course durvalumab, which is a PD-1 inhibitor, another class of drug, sorry, PDL1 inhibitor, is being tried in other circumstances also. But as of now, since we have evidence for durvalumab as a maintenance, we are actually using in 2 patients. They have stopped the compassionate program. That Astra used to have a compassionate program, and we have recruited 2 patients, and both of them are doing relatively well for 1 year. But since we do not have the data on others, and presently this drug is not available in India, we do not have, so that's why we cannot use. But you're valid, I'm sure there will be other trial which show durvalumab will work in other. Absolutely. Thank you.